So we're going to talk about pelvic floor rehabilitation now. And rehabilitation is a little bit tricky in that we have to start by shifting our perspective. So the pelvic floor is often the victim in the pelvic floor dysfunction. It's not an aggressor, it's not the problem. I'm going to try to show that to you through this talk. But if we look at the pelvic floor as a problem and we try to treat it, things may or may not exactly get better. Modern medicine has a problem. We tend to divide the objective from the subjective and expect to succeed. The thing is, most diseases are a mix of both of these things. So if you throw out half the information, you're not going to get success. The other side is pelvic floor rehab is not Kegel exercise only. Yeah, it's what we learn in medical school. It's one word you can write on an exam and be okay. But reality is very, very different. Kegels can actually make things worse, and most of our referrers don't actually know this. But once the diagnostics and therapeutics of the problem are over, we're left to treat the person who has a problem. And as physiatrists, we address this with rehabilitation. So the first step is to understand that no two cases are identical, even if their clinical features and severity are the same. The path that they took to end up in front of you is relevant to the treatment, and we need to get a grip on those subjective features if we want success. Now, to analyze the subjective, we have to look at two different things. One is the experience and how the experience is handled. And the experience would be personal factors or lifestyle factors. What a person experiences in their life. How it's handled is by the autonomic nervous system, and what we're going to talk about is the inflammation reflex arc. So autonomic nervous system and then lifestyle factors are how we analyze the subjective. So this is our standard neuronal reflex arc as a control center, an efferent, an effector, and an afferent. And from there, you can see when we frame in terms of the inflammation reflex arc, what is this? It is essentially a system that promotes healing throughout our body and preserves it. If cells die, this cleans out the waste. If there's damage, it heals it up. Now, the inflammation reflex arc is part of our vegetative functions, and it has a control center in the rostroventrolateral medulla, or the nucleus ambiguous and solitary tract, which you might know as vagus nerve origins. So the efferent will be the sympathetic and parasympathetic nervous system, which operates with acetylcholine on 7-alpha-nicotinic receptors. And that is mostly found in the immune system cells, which sit outside of the ANS, the autonomic nervous system. These immune system cells, when acted upon by these free nerve endings of the autonomic nervous system, will now release cytokines. And the cytokines are detected by the vagus and the glomus paracrine tissue, and they tell the control center, hey, the job is done. Don't worry, we'll take care of the inflammation from here. If this was a closed system under complete control of the body, things would be okay, but that's not the case. We have endogenous ligands like HMGB1, a nuclear protein, heat shock proteins, uric acid, interleukin-1 alpha, annexins, nucleolin, all that act on this. Exogenous ligands like lipopolysaccharide, lipotecoic acid, CpG-containing DNA, dsRNA, hemazone, flagellin, which you might note as bacterial products. So HMGB1 nucleolin can happen in getting to circulation when tissues die. That's normal. That's not a big issue. Too much death will mean more inflammation, but this happens. Bacteria in circulation do not belong there, so the body will aggressively fight them off. But the question is, how is this happening? Why is it so out of control? And you have to look at modern lifestyle for that. So the way we respond to environmental stimuli can do this. If I have a negative response to a genuine situation, I could have heat shock proteins released into circulation that trigger the inflammation reflex. Memory is stored in the amygdala. I give this talk, someone doesn't like it. The way they ask a question makes me upset. Heat shock proteins, inflammation reflex. Bad posture in itself will deform sarcomeres. It will induce inflammation, lactic acidosis, fibrosis, trigger points. Again, inflammation reflex arc. Pro-inflammatory food. Many foods come in a nice shiny wrapper and a lot of preservatives. Things like sodium benzoate can strip off the GI lining, allowing gram-negative bacteria to get into circulation, exogenous ligands, inflammatory reflex arc. Myofascial trigger points, again, independently, can go and activate inflammation reflex arc. Age proteins from people who are diabetic or just obese independently activate inflammation on their own. And if you really, really think about it, most of these things are what we find in the modern world. Why? Because people have small smartphones that they can stare at all day long and watch all kinds of doom scrolling, triggering material that makes them get anxious until inflammation reflex arc just trips on its own. What we're seeing though is maladaptive responses to stress. Stress is a good thing and makes the body stronger. If it doesn't kill you, it makes you stronger, but too much stress will eventually kill you. So when we don't respond to stress properly, we get this problem. And eventually it becomes a vicious cycle because we trigger ourselves into activating the inflammation reflex arc that then leads to more pain, that leads to more stress, that leads to more pain, that leads to more stress, and eventually we get into dysfunction. Nobody wakes up with a pelvic floor disease. They slowly progress into it. And we all start from a state of relative health. We all know when we were at our best shape. Some in our 20s, when the world was a great place to be and we want to conquer it and do great things to it. And stress comes along. And if we don't handle it well, we might react badly. But we know, okay, it's not worth it. We have to be calm. But stress comes again, and we might have a bigger reaction. And this is the time where you might come out with a headache or a backache or just feel really bad in ways you can't explain. But it doesn't stop. It comes back again. And we know, okay, it's stress. I won't react so bad, but it comes again. And now we have a big reaction. This is when the person gets stressed and they have major back pain and they need medications for it. Right? And this happens so much that eventually the entire baseline starts to shift closer and closer to being unwell, meaning pre-disease maladaptive processes become so bad that disease emerges, the latency period between events decreases until the baseline shifts, and from there people are always unwell, and there's a point of no return or disease processes become autonomous. People say, there's so many people that have obesity, they're overweight, they have poor posture, they have all these triggering things, but they don't have pelvic floor dysfunction. So why do people come with pelvic floor dysfunction? And the answer is things like myofascial pain syndrome, life stressors, inflammatory bowel syndrome, irritable bowel syndrome, depression, post-surgical adhesions, infection, cancer, trauma, endometriosis. All these can actually start the spark that eventually manifests as a pelvic floor dysfunction. And if you look at these post-surgical adhesions, infections, cancers, traumas, IBS, they can often be endometriosis. They can all be linked into the somites that govern the pelvic floor. So when and where does it all begin? There's two types of people we see. One kind is the person who has had some past trauma. They've had some event that really bothers them, and there's life events that they internalize to protect themselves, but this becomes the basis on which they act. And now you have this central system moderating the peripheral system. I'll expand on that in a bit. Or you have people who just live a regular life, but they're continuously overexposed to focal stressors in particular areas. This is someone who has a mechanical job but is otherwise happy, or someone who is bombarded by all kinds of blue light, doom scrolling, and social media toxicity. And now they come back with these kind of problems. This is peripheral modulating the central. What I mean though is the issue is in the tissue, and the tissue is the fascia. And the fascia has all kinds of receptors in it: nociceptors, mechanoreceptors, proprioceptors, thermoreceptors, cryoreceptors. You name it, there's a receptor for it. They feed into the dorsal root ganglion and the dorsal horn. Now, that in itself isn't a big problem, but that's not the only thing feeding in. Look at this. You have viscera, you have blood vessels, skeletal muscles, tendons, muscle spindle. All these things are going to try to feed into the same dorsal horn, but you have fascia that is such a big part of the body jamming the signal with its signals of pain and discomfort and deformation. And what you get is a traffic jam. where the fascia is blocking up the main channels in, and the basic organ functions, bowel, bladder, can't get their signal in. And now you find constipation, urinary flow problems, sex function problems, all kinds of problems emerge because the fascia keeps jamming this. So this is how disease starts to begin, but then it evolves. So we have this jamming signal on this level that eventually leads to sympathetic sprouting, that leads to basket formation, that leads to central sensitization. And from there, you can have a peripheral somite in the pelvic floor modulating the brain, making a person more and more anxious. Or you could have the brain in a person who has a bad memory modulating their pelvic floor, making it tighter and tighter. So we're back to Pescatori. This is our second talk of this. So Pescatori made this model of his iceberg. And Pescatori's iceberg says what we see as dysfunction is not the only thing. There's many more things that go on. If we don't look for it, they're not going to get proper success in our treatment plan. So Goshen extrapolated Pescatori's iceberg, which was made for pelvic organ prolapse, and he extrapolated to chronic pelvic pain. That's what you see here. So this, Pescatori's iceberg for chronic pelvic pain, has residual urine, obstructed defecation, nocturia, stress incontinence, frequency, bladder emptying, urge incontinence, all in there. And if you don't identify these and treat them, you're not going to get the right outcome. Sometimes when you treat them and they get better, these things will improve too, but you should be aware of it. But from there we get phenotypes. So we get an organic phenotype, a mixed phenotype, and a non-organic phenotype. And who cares about phenotypes? Really, here's our treatment options. Let's get things going. But we want to understand natural history of disease. And that's how we do this. So the organic will have more objective features than subjective. Mixed will have a mix of both. Non-organic has more subjective than objective. And from there, here's our treatment options, which we'll expand on in a bit. But there's three outcomes. One, whatever you do really, really works. Whatever you do works until it doesn't work anymore. And then lastly, whatever you do, they keep getting worse. Now, everybody hates to deal with these last two kinds of patients. They're just a nightmare to deal with. You're trying to help them, and they keep getting worse. But who are they? And if we're not careful, these last two categories, 50% end up in anxiety or depression if they don't already have it. So we know that the people who are mostly organic issues, where it's just the muscles and dysfunction alone, whatever you do is going to work. But if they have mixed, they may not do that. And if they're non-organic, they definitely won't do that. But the question is, the easy cases, you can send to a quack, you can send to a therapist, you can send to acupuncture, whatever you want. They're going to get better. It's these last groups that don't get better that we really want to understand. So there's tangible factors. We spoke about them in the previous talk on the exam of the pelvic floor, but there's intangible factors also, like things that are modifiable, like lifestyle factors. There's also non-modifiable factors, like gender. The female brain is more sensitive than a male brain. The way it processes signals is very different. Sex hormones, testosterone and estrogen increase the resting muscle tone. Aging, as people dehydrate, muscles become less and less flexible. Sarcopenia emerges. And what personality cluster they fall into determines how they interpret life events. Some people react badly to small things and ignore major things, depending on what their personality cluster is. But the bottom line here is what we all ignore is really a person's ability to bounce back from being ill, or their resilience. And when resilience gets compromised, you see people who keep getting worse and worse and worse and worse. So we've spoken about analyzing the subjective and natural history of disease. Now we'll look at treatment options. So pelvic floor exercise is the most commonly prescribed thing. But it's not the main thing. It's part of what's going on, and I'll show you. See, what is it? It's essentially if a muscle is tight, stretch it out. If it's loose, tighten it up, and correct imbalances across the pelvic floor. That's great, you know. It's ideal for people who have an organic or mixed phenotype. It addresses symptoms, not the cause. The results usually will be fast. But it's not sustainable because most people stop exercising when the symptoms fade, and the expected response is kind of a slow and steady response. They do the thing, they slowly feel better. The next thing is EMG biofeedback. Most people have never seen their other end. They don't know how it works. So if you connect into an electrode set that has a screen, they can get an idea of how things work. And this is really good for organic cases and mixed type. Again, immediate results. It addresses symptoms. It's not sustainable. And most will stop exercising when symptoms fade. With the expected response is again going to be this. They've never seen their pelvic floor, and now they make a muscle contract. A line goes up on a screen. Presto, it makes complete sense. They get it. It's a very good device. Postural correction. What is it? It's correcting global postural imbalances. And this is going to look in organic and mixed phenotypes. It gives immediate results. It addresses symptoms like the myofascial trigger points, but again, it's not sustainable because most people stop when the symptoms fade. The expected response, again, is a slow and steady response. Myofascial trigger points are what we saw before, scars inside the muscle. You inject them, and it's good for organic and mixed. It gives immediate results. It addresses symptoms. It is not sustainable because you need doctors to do this. Now, therapists have their own version of this, which is putting dry needles in. Therapists aren't allowed to inject drugs. And studies so far show us that wet needling with medications is more effective than dry needling. But this is kind of like flirting with needles. People who don't want injections right away might flirt with these kind of dry needling procedures as a start. The expected response is instant relief. They have pain, you take away the pain, they feel good. Wonderful. The next is nerve blocks and hydrodissection. So there are times where the nerve can get trapped or have adhesions around it where it can't function properly. Ideal is going to be organic and mixed. It gives immediate results. It addresses symptoms, and it's not sustainable because you need a doctor to do this. But the expected response is, again, instant relief. If the nerve is really trapped and you hydrodissect it free, they get relief. Great. The next is neurotherapy. What is neurotherapy? It is essentially injections to stellate ganglion, vagus, celiac, and pelvic plexus. There's much more to this. It's its own separate master's degree in most of Europe. But roughly, we're looking at modulating the autonomic nervous system. I'm showing you a picture that I took from the internet of addressing the celiac ganglion through the anterior abdominal wall. You go through the stomach and you go through the liver to end up on the junction of the hepatic artery and splenic artery, where you can put local anesthetic. This is made for all types of people. It gives immediate to delayed results. It addresses symptoms. You need a doctor, an actual medical doctor to do this. And right now, no one else in India actually does this aside from myself. But it produces a detrimental change in symptoms until the person reaches a stage of ease. Now, slow and steady is the progress, but when they have psychosomatization, visceral-somatic overlap, this really comes in use. Ergonomics. We're shifting our treatment now a little bit. Ergonomics essentially is people tend to droop their heads forward and send their sacrum backward, and this creates a lot of deformation forces across the pelvic floor. So unsupported sitting requires greater pelvic floor muscle activity than supported sitting, using the back of the chair. But the SI joint should line up with the C1, C0 joint, and we should be able to send our sacrum forward and our head upward and backward. Something like what you see here. Now, this is ideal for organic and mixed. It's immediate results when they really get it, but keeping them doing it is a bit hard. It addresses the cause. This addresses the cause of spinal deformation. It is sustainable, but many people do like to slouch, so you teach them what correct posture is, and they need some motivation to keep doing it, but it can be done. It's not hard to send the sacrum forward and the head upward and backward. The expected response is confusion. They're sitting all this time. You're telling them how to sit better to fix their pelvic floor? You're the doctor, they believe you, but it doesn't really make sense sometimes. Breathing correction. When we inhale, the diaphragm descends, pelvic floor lengthens. When we exhale, the pelvic floor contracts, abdominal wall contracts. When this is in dysfunction from an overstretched anterior abdominal wall or a weak core or pelvic and visceral fat, the diaphragm starts hammering the pelvic floor. It really hammers it and stretches out or forces it to become tight. And this is what often exacerbates the myofascial trigger points that we see in the first place. This ideal for organic and mixed types is delayed results because you have to really train a person to breathe properly. Again, it addresses the causes, but it's very hard to sustain because people need awareness, and the expected response is confusion. They're breathing already. You're going to tell them how to breathe better to fix their pelvic floor. They don't get it. It doesn't make any sense to them, but it really does work when they do it properly. 6 pillars. This is an emerging concept in healthcare where we look at wellness and preserving wellness rather than fighting disease. So what is it? 150 minutes of exercise per week, nutritious diet, avoid risky substances, stress management, restorative sleep, social interaction, essentially this. And who needs it? Everybody needs this. And the results are delayed addresses the cause, and it is sustainable because now you're giving the owner manual. So they are completely empowered to take care of themselves. The expected response, they like it, but they hate it. And it really sounds good to be peaceful, not overweight, physically fit, eating healthy, sleeping well, but the path that it takes to get there is kind of hard. It's a little bit of a sacrifice. Weight loss. You can see this morbidly obese person, the chunk of fat pushing their bladder down, the pelvic floor has to spasm to hold everything in place. It's not even designed to do that, but now it has to. The ideal phenotype is anyone who's overweight, but organic and mixed most commonly. People with non-organic issues and antipsychotics that make them overweight will need this. It produces delayed results because getting to ideal BMI is hard. And especially for Indians, we're already prone to behave like cardiovascular patients at lower BMIs. So we should be aiming for a BMI of 22. It addresses costs and sustainability. You're giving the owner the manual, so they should be able to fix themselves. The expected response, again, is they like it, but they hate it. No one wants to be overweight, but there's particular habits they have that lead to it. And controlling those habits gets them to underweight or normal weight. The simple cheat is always going to be you can eat as much as you like, but it should be vegetables. Animal source foods, high carbohydrate meals tend to lead to this deformed, obese, overweight posture. Personality augmentation. What is it? It is essentially knowing who your patient is as a person and knowing which cluster they fit into. Cluster A, detached from social relationships, the paranoid schizoid. Cluster B, disregard for others, impulsive and deceitful, or extrovert and unstable. This is your narcissist. Or cluster C, anxious, withdrawn, where they fear criticism, rejection, or disapproval. And you can see this in their affect and the way they behave with you sometimes. You have to really get to know this person to help them. The way to treat them is motivational interviewing, setting goals, and teaching them to be accountable for their own behavior. No, they can't just spend their day thinking negative thoughts and think that they're going to be perfectly fine. No, and when they're younger, maybe, but now their body's getting older, and any stress will activate heat shock protein, the inflammation reflex arc. So the ideal phenotype is non-organic and mixed. It's delayed results. It addresses the cause. It's sustainable because you're giving them the manual to handle themselves. The expected responses, confusion. Are you attacking them? Are you telling them not to be who they've been all these years? When you look at it, we all have these different clusters of personality within us. Every normal person has a healthy amount of paranoia, a degree of extroversion to interact with society, to look for affirmation from their peers, and also a tendency to withdraw and contemplate on what they're experiencing. It's when these things get out of control that you find these abnormal personalities emerge. Are you attacking them? No, you're trying to help them get back to balanced. Mindfulness techniques. What it is, we think it's this But we live in the most populated country in the world. It's 1/3 the size of the US and the highest population, right? You're not going to get this. What it is instead is actually being aware of how we do every little thing, enjoying all the little moments that make up what we call life. It is ideal for non-organic and mixed types. It's delayed in results because it takes a lot of time to learn to become aware. It addresses cause and sustainability. We're giving the owner the manual, but the expected response is kind of, really? I have to do this thing so slow? I could be doing 10 more things in the same time. Why should I peel the orange and smell the citrus as it comes out? Why should I taste every little slice of the orange when I can just eat the thing and do the next job? But it's not about the destination, it's about the journey. Most of what I've spoken about has become very, very abstract, and this is the worst of all of my slides. This is non-doing. We have a problem in modern medicine where we tell people to do something. They come to us, and as the authority, we say, do this, do that, you'll be fine. And if they get better, we're happy. If they don't get better, it's out of our scope, so we refer to someone else. When we refer to someone else, they'll tell them, do this, do that. And if they get better, great. But if they eventually end up in a situation where they're not getting better, they will start running from pillar to post saying, just tell me what I'm supposed to do. And as clinicians, we're so subspecialized now, we don't really know what everyone else does. So we tell them, look, whatever you're doing is perfectly fine. It's okay. Just keep on doing, keep on doing, keep on doing. And it's not wrong because you can see many of the interventions we spoke about actually take time to produce results. But if they're not getting results, we have to be aware of that too. So if they're not getting results, there's a reason for it. It's illogical to expect more doing to make things better. The way we do every little thing affects how we do everything. It's not what you use, but how you do it. It's not what you do, but how you do it. And they have to stop overdoing. And this is a challenge, especially in the modern world. Who needs this? Everybody. The results are delayed because you're going to really train a person to be just a regular person who does not react but responds. It addresses cause and it is sustainable if the mindset shifts. The expected responses, they get to peace of mind. They can be balanced in this world of chaos that we live in. Now, I've thrown so many treatment options at you at one go, it would make no sense if I didn't frame these into some structure. So here we go. Acute and chronic, mild and severe. Now let's populate this with treatment options. If a person comes to you with pelvic floor dysfunction and it's not that bad symptoms, and it's kind of fresh, you could look at pelvic exercise. If they don't understand, you could do EMG biofeedback. If you get those results and you really want to look at posture, because correcting this will fix a lot of problems. If they're having severe pain in the acute phase and the chronic phase, you can do myofascial trigger points, you can still do nerve procedures, but neural therapy is one of the things that bridges acute to chronic. Now, if you've done all of this and they're kind of better, but they're not fully better, you probably have a non-organic or a mixed type problem, in which case weight loss, ergonomics, personality modification, 6 pillars, breathing correction, mindfulness, non-doing. That's what you're going to focus on for your treatment plans. When people come to these kinds of talks, they want something quick and dirty. No one has time anymore. They want the too long didn't read version of it. And this is what I show my colleagues because, again, majority of doctors in India have never heard of physiatry, so they think it's physical therapy, or they think that we just order therapists what to do. My hope is that you've understood we do much, much more than that. But there's something more. You see, rehabilitation is much more than just physiotherapy. Physiotherapy is a part of it. And that being the case, the question our colleagues get is, when do we need more than just a physical therapist? Now, we need some kind of test to sort these things out. And what we're trying to sort out is organic from mixed and non-organic. So, if a person, while urinating or defecating, can cover their eyes or put their hands over their head, and then defecate and urinate with ease compared to before, whatever you've done with them, these two things will address the myofascial chain imbalances across their spine, allowing the pelvic floor to function better and faster, thereby telling you any therapist is okay, even the acupuncture, even the shaman quack, they're going to get better. It's not a big problem. This is just a muscular issue. But there's a real inconvenient truth that comes into play with pelvic floor and most of rehabilitation. That is, rehabilitation begins with us as medical practitioners, the real doctors. And those who can't understand this will confuse patients they refer because they'll say, go get some exercise, go ride a cycle, go do something. Now, if we can't be role models, we will end up spreading disease. It's kind of like this, the robber who tells you, don't steal, okay? And this brings to mind at least 50 questions. Why is he saying don't steal when he's stealing? Does he want to steal more? Does he feel bad and he's trying to correct you from doing wrong things? Who knows? Who cares? It's hypocrisy to be a medical practitioner and not know how to take care of yourself, but tell other people how to take care of themselves. Thank you.